Our last lecture of this day is Cutaneous Manifestation of Nutritional Deficiency by Dr. Sahana Srihari, Assistant Professor at Adesh Institute of Medical Sciences and Research from Bathinda. Over to you, ma'am.
Please do not start my time right now. I have a small announcement. We will be conducting a crossword at the end of my talk. You'll all be given forms where the crossword puzzle is given and the clues are there. Most of the answers are there during my talk. So this is one way to make sure that you're all there with me on the talk. So, and 3 winners will be declared and you'll be given prizes. One more thing I wanted to say is that nowadays all of us are updating and learning newer concepts. How many of us have time to get back to our textbooks or the basic concepts? If I have sir's permission, I would just like to ask 2 questions to the audience. Which vitamin is known as vitamin in search of a disease? Can anyone answer? Why so? Which vitamin and reason why it is known? Someone answered vitamin E. Why is it called so? There's no known disease because of vitamin E deficiency. And the other question is, which organism has the ability to synthesize all vitamins? Which organism in particular? There's just one organism which has the ability to synthesize all the vitamins and does not need any external vitamin to be supplied. No? These are questions from our very own textbook of Biochemistry by Satyanarayana. So the answer is E. coli, Escherichia coli. So I start my talk now. Yatha annam tata manaha. What you eat, you become. Shukra dhatu shuddhihi sukam jivanam. A pure diet leads to a happy life. The Gita calls for discipline and moderation in all spheres of life as a means of healthy living. A very good evening to one and all present here. The topic for my today's talk is cutaneous manifestations of nutritional deficiencies. We'll be discussing under the following headings. Now, to know the etiology of nutritional deficiency, one is decreased intake which can occur due to poverty, ignorance, food fatism, crash diets which have become very famous nowadays, and anorexia nervosa. Other causes can be increased requirement as in during growth, pregnancy, lactation, fever, or hyperthyroidism. Now we shall discuss about protein energy malnutrition. Under this we have kwashiorkor, marasmus, and the marasmic kwashiorkor, which is the most severe form of malnutrition. In kwashiorkor, the child has 60 to 80% of the expected weight. It occurs mainly due to protein deficiency with an adequate calorie intake, showing features of hypoproteinemia and edema. This protein deficiency can be qualitative or quantitative or both, and in 20 to 40% of cases we do find cutaneous lesions. Whereas in marasmus there is less than 60% of ideal weight, there is protein and calorie deficiency and loss of subcutaneous fat. We shall see some patients with protein energy malnutrition. This is a child with kwashiorkor showing flaky paint dermatosis. There's hyperpigmented macules and patches and minimal erythema. We can also see that there are few changes in the hair. The child is apathic and irritable. Here in this picture, we do find that there is some shiny skin which is due to the edema. The changes in the hair are dry, lusterless, brittle hair with decreased pigmentation. Whereas in marasmus, the child is very irritable, the skin is very dry, scaly, and there are ichthyotic changes in the skin. There are dry patches. Here the acral areas are involved in this picture, and there can be hyperlinearity in the palms. This is again another picture showing a marasmic child. There is loss of subcutaneous fat, the child is apathic, and there is increased wrinkling on the skin. We next discuss vitamin B2 or the riboflavin vitamin deficiency. The onset can occur with 3 to 5 months of inadequate diet. Here we can see that the child has angular cheilitis. The other lesions that can be associated are seborrheic dermatitis like rash, dyskeratotic follicular papules with scaly erythema. The child can also have ocular and CNS manifestations. There can be angular stomatitis or perlic with maceration. There can be angular cheilitis, lip involvement with vertical fissuring as shown in the picture here, and the tongue can have glossitis with atrophic filiform papillae and enlarged fungiform papillae. Next we discuss pellagra or the vitamin B3 deficiency. The etiology can be in persons having staple diet of maize and jowar, the niacin is in the bound form. It is not freely available. So one thing that we should keep in mind is we can counsel the patients to do a process called nixtamalization. This is where the grains are soaked in lime water overnight so that the next morning when it is used, you have the nixtamal and the nejayote, and the bound niacin is available in the free form and easier for absorption. It also occurs in chronic alcoholics, Hartnup disease, Carcinoid syndrome, or drug intake. The cutaneous features are hyperpigmented, scaly lesions with a sunburn appearance, as shown in the figure here. The lesions resemble a sunburn. The characteristic 4Ds in pellagra are dermatitis, diarrhea, dementia, and death. Here we also see lesions called Cassell's necklace, that is sharply demarcated lesion on upper central chest and neck. When this continues over the anterior part of the chest, it's called cravat. The lesions are erythematous, scaly plaques with well-defined borders. It's more commonly seen on the elbows and knees or the bony prominences. Scalp may be involved, and photodistribution is a feature. We also have Pellegrin's nose, where there is dull erythema or butterfly rash with scaling on the bridge of the nose. Scrotal erythema can be associated. Next we discuss B6 deficiency, the pyridoxine deficiency. There can be atrophic glossitis and angular cheilitis. I would like to say that vitamin B complex deficiencies never occur individually. It's always a combination of deficiencies, and no single lesion can pinpoint to a specific deficiency. Here the child has angular cheilitis. The hair is dry, lusterless, brittle, and hypopigmented. The patients can also present with aphthei-like ulcers and other neurological symptoms. Now coming to B12 or cyanocobalamin deficiency, causes can be lack of secretion, inhibition of intrinsic factor, abnormalities in receptor site of ileum, or inadequate intake. Features can be angular cheilitis, aphthei-like ulcers as shown here. We'll have to differentiate it from other lesions in the oral cavity, like Sir was discussing about Koplik spots. And even in there can be hypopigmentation and a briefly red tongue. In the skin, there is symmetrical hypopigmentation mostly on the knuckles. In the nails can show pigmented streaks. Vitamin B12 deficiency can also cause premature graying of hair. So this is one feature we need to keep in mind. And also vitamin B12 is one of the B complex vitamins that is not very safe in very large doses. Because vitamin B12 excess can again cause the same symptoms as caused by vitamin B12 deficiency. Pins and needle sensation, neurological manifestation, and recently in our OPD I have been observing that patients who present with telogen effluvium, when the investigations are done, they have very high vitamin B12. This is maybe because of the fact that doctors all over are negligent about prescribing vitamins, and it is given, and patients too follow media where every single person becomes a doctor these days. They've been telling things about nutrition a lot. Next we discuss vitamin C deficiency, the scurvy. Here the cutaneous lesions are perifollicular purpura or hemorrhage. The common sites are upper arms, buttocks, shins, trunk, or the thighs. There can be petechia or ecchymosis, and delayed wound healing is one of the features. One more feature is woody edema of the legs. Here we would like to show that in vitamin C deficiency, we can also have corkscrew and swan neck deformity of the hair strands, as shown in the figures, with associated petechiae in a predominantly perifollicular distribution. So the figure C shows the same patient after 3 months of vitamin C supplementation, demonstrating resolution of the lesions. Other radiological features can be pseudoparalysis or the scorbutic rosary. The tongue can have features with some amount of exfoliation and prominent papillae. There can be spongy hypertrophic gums, loosened teeth and foul odor in the oral cavity. Perifollicular hemorrhage is another feature in vitamin C deficiency. Now here's a case, there's a case by Dr. Arun Inamdar sir. There's a 7-year-old girl with alopecia since 6 months. It was initially thought as vitamin D resistant rickets, but on X-ray there was white line of Frankel with signet ring epiphysis which suggested scurvy or vitamin C deficiency. After 2 months of treatment there was marked improvement and regrowth of hair. Next we come to vitamin A deficiency. Here the features are grouped hyperkeratotic and pointed follicular papules, predominantly on the elbows and knees with the central keratotic honey spines. This condition is known as phrynoderma or the toad skin. This can occur with other deficiencies like vitamin E, B complex, vitamin C and essential fatty acids also. These are again pictures showing phrynoderma. Vitamin A deficiency can also be associated with ocular manifestations with delayed adaptation to dark and nyctalopia and xerophthalmia, and bitoid spots can be seen in the eye. Next we come to zinc deficiency. It can be genetic where it's termed as acrodermatitis enteropathica or the acquired zinc deficiency. Here the lesions are erythematous plaque with well-defined borders, characteristically sparing the upper lip. The lesions are most commonly associated in the periorificial areas and the acral areas. In the acute phase, the lesions are eczematous and erosive, favoring the acral areas or the periorificial areas. In the chronic deficiency, it turns into psoriasiform dermatitis. Here are some pictures showing lesions occurring in zinc deficiency. Again, zinc deficiency, they can be associated with angular stomatitis and glossitis with superadded candidiasis infection. There can be hair, nail and eye changes also. Here we can see that there are erythematous plaques with well-defined borders. Lesions in the perianal area, which is very characteristic in zinc deficiency. Here we describe 2 male siblings aged 17 and 13-year-old born to a second-degree consanguineously married couple. They had genetic zinc deficiency and in between when they had stopped taking the medication, they presented to the hospital with these lesions and they were supplemented with zinc and counseled regarding lifelong supplementation with the same. In the hair, we can find striations on microscopy. This again picture showing lesions in zinc deficiency. Here we can see that it characteristically spares the upper lip. Now coming to iron deficiency, the clinical features again include oral cavity lesions like atrophic glossitis, angular stomatitis, can also present with generalized pruritus, hypo or hypopigmentation. Features in the nails are spooning of the nails or the koilonychia. The nails can be brittle because of decrease in disulfide bond formation and there can be longitudinal ridging seen in the nails. Hair changes can occur. There can be telogen effluvium, diffuse alopecia, and premature graying of hair. Now coming to biotin. This occurs due to deficiency in the enzyme biotinidase. The rashes are eczematous. It may be extensive. There can be associated cheilitis or chelosis. Here in the picture we can see that the child has eczematous skin lesions. Also associated can be seizures, ataxia, breathing difficulty and delayed development. There are some hair features also where the hair is dry, lusterless, brittle and hypopigmented. Next we discuss about copper deficiency. This condition is known as Menkes disease or the Menkes syndrome. It occurs due to mutation in the gene ATP7A protein, leading to copper deficiency. The hair characteristically is kinky. This is a child with Menkes disease, and there's a microscopy in the hair where the hair strand appears like a twisted chain. There's kinking at regular intervals. Next, we discuss Hartnup disease, which is autosomal recessive disease with skin changes appearing as early as 10 days of age. Cutaneous photosensitivity is a hallmark with pruritic pellagra-like rash, and there can be chronic eczema. The skin reddens after exposure to sunlight. Other associated features are the CNS manifestations. Next, we discuss vitamin D resistant rickets. This is a rare autosomal recessive disorder due to mutation in the VDR gene. Alopecia is a characteristic feature. Patients with alopecia are generally more resistant to treatment with calcitriol than those without alopecia. These are the bony changes. Now, coming to nutritional deficiencies in eating disorders, that's anorexia nervosa or the bulimia. The non-specific skin changes are xerosis, pigmentary changes, lusterless hairs, and impaired wound healing. The specific changes can be those associated with scurvy, pellagra, or the zinc deficiency. There are certain GI disorders, pulmonary and disorders, and surgical causes that can cause nutritional deficiencies. Dermatological disorders like atopic dermatitis, epidermolysis bullosa, and erythroderma can be associated with nutritional deficiencies, and there are certain miscellaneous causes. Having said all the above, I would like to emphasize that water these days also comes under nutrition. So intake of water is very important. Nowadays in the market we have bottles which with marked timing, 8 a.m., 10 a.m., 12 a.m. that you are supposed to have so much of water within that time. So intake of water is very important. This is one of the creative that I have made to remember the nutritional deficiency and the manifestations, head to toe manifestations in each nutritional deficiency. Thank you.